Okay, so welcome to this next video in which we are discussing the glucocorticoids for asthma. So we've now discussed the pathology of an asthmatic attack. We've discussed how the adaptive immune system is going to launch a humoral adaptive immune response against an allergen, and it's going to result in the production of immunoglobulin E molecules against this allergen. Okay, and these IgE molecules are going to get loaded on mast cells in the lamina propria, and then when you get a secondary exposure to the allergen, what will happen is that will bind to the IgE that's mounted on these Fc epsilon R1 receptors on the surface of the mast cells, and that will trigger the mast cells to release all sorts of pro-inflammatory molecules which will cause the asthmatic attack. Now, what we just want to discuss before we move on to the glucocorticoids is the fact that you are going to have to get a secondary immune response to this allergen. And the reason is that when we had this first primary exposure to the allergen and we breathed in the allergen for the first time and launched a humoral adaptive immune response against that allergen, okay, we produced plasma cells which were chucking out IgE that was against this allergen. The problem is that problem or good thing is that those plasma cells don't live forever, okay, so they gradually will fade from the blood and from the bone marrow. Okay, so the plasma cells will start to be removed from the blood after a few weeks, basically. Okay, in addition, that means that we're going to no longer be producing more IgE. Now, the IgE will be removed from the blood very quickly. Okay, so blood levels of IgE will go down. Now, the IgE that's mounted on the surface of the mast cells in the Fc epsilon R1 receptors, that will remain on the mast cells for quite some time, okay? So it will remain for months, but it will eventually go. So, in principle, if you waited long enough, then if you were exposed to the allergen again, you wouldn't get an asthmatic attack because there would be too little IgE on the surface of the mast cells to now trigger it, basically. Okay, so what's going to have to happen is at some point you're going to have to produce the IgE, basically, and this is going to happen every time you re-expose yourself to the allergen. So every time you re-expose yourself to an allergen, not only are you going to get an asthmatic attack, but also you're going to be reactivating the adaptive immune system to produce IgE molecules and therefore keep the asthmatic attacks capable of happening, basically. So you're going to be reproducing your stock of IgE molecules and mounting it on all the spare receptors on the Fc epsilon R1 receptors on the surface of the mast cells. Okay, right. So, how then does the adaptive immune system get activated again? Because now it's going to actually get activated far quicker than it was activated initially. So initially what we had was a primary adaptive immune response against this allergen. Now what we're going to have is a secondary adaptive immune response, and this will result in the production of IgE far quicker than the primary immune response produced IgE. So basically, what you have to understand is we're going to produce memory cells. Now, let's go back to our discussion of B-cell activation. Okay, so remember, the germinal center B-cells, we talked about how they could differentiate into plasmablasts. The plasmablasts could divide, and then those plasmablasts could differentiate into plasma cells. Okay, and these plasma cells then went into the blood and started secreting IgE. So this germinal center B cell has undergone class switching. Okay, so it's switched its antibody type to IgE. Okay, and then it differentiated into a plasmablast, and then the plasmablast divided and resulted in plasma cells, which then produced the IgE as well. Now, these germinal center B cells can also differentiate into what's known as a memory B cell. Okay, so let's say here we have a germinal center B cell. Then it can also differentiate into what's known as a memory B cell. Now, again, these memory B cells have undergone the class switching. So this memory B cell has IgE molecules. It can only produce IgE molecules, and also these IgE molecules will be specific to that allergen. Okay, so the germinal center B cell will differentiate into a memory B cell. Okay, now, what is the purpose of these memory B cells? Well, they're going to sit in B cell follicles, and they'll also circulate within the blood, and they can be activated if the allergen reappears, basically. Okay, so if the allergen if you're re-exposed to the allergen, so let's say you inhale the allergen for another time, so a secondary exposure to the allergen, this is going to cause the asthmatic attack which we've just described, but it's also going to activate these memory B cells, okay? Now, these memory B cells will then differentiate into plasma cells, and this process isn't very well understood. It is likely that you only need the allergen to be to come into contact with the memory B cell, and then the memory B cell will be activated, but we don't know. It's plausible that it still requires T helper 2 help, and we'll discuss that in a moment. This process is very, very weakly understood, basically, the activation of memory B cells. Okay, so what happens is the allergen comes in to the blood. Okay, so you've got allergen in the blood, and it's going to activate these memory B cells, and what's then going to happen is these memory B cells are going to differentiate into plasma cells, so they're going to result in the production of plasma cells which will produce the IgE molecules. Again, what will happen generally is that they will firstly divide, okay, and then they'll produce plasma cells. So you'll get many plasma cells, basically. So a memory B cell won't just produce one plasma cell, okay. So here is a plasma cell, however. So what's going to happen is the memory B cells, once they re-see the allergen will cause the memory B cell to divide and then differentiate into plasma cells. So you're going to produce lots of these plasma cells, and all of these plasma cells will have the same antibody, the same immunoglobulin as this memory B cell, which, remember, was against the allergen and was an IgE type. Okay, so this means that very quickly you can produce plasma cells which are going to be able to secrete IgE. These plasma cells will circulate in the blood, and then they'll take up residence within the bone marrow and chuck out the IgE. And this will be happening every single time you re-expose yourself to the allergen, basically. Okay, so that is the memory B cells. However, it's debated whether the memory B cells only need to see the allergen in order to activate. Of course, naive B cells, they needed to do far more than just see the allergen. They needed to get T helper 2 help. And it is plausible that the memory B cells also need T help as well. And there is a form of memory T cell as well. So, remember when we studied T cell activation, so let me just find it. Okay, so when we studied T cell activation, we saw that a naive CD4 positive T cell that has been activated would turn into a T helper 0 cell. That would divide and produce a whole population of T helper 0 cells, which then differentiated into T helper 2 cells. Now, once the adaptive immune response has finished, these T helper 2 cells will start to die. However, some of them will escape death and instead will differentiate into memory T helper 2 cells. Okay, whoops. So this is a memory T helper 2 cell. Okay, now, what can happen is, if you are re-exposed to the allergen, what will happen all over again is professional antigen-presenting cells will phagocytose the allergen into a phagosome. They'll break the allergen down, and they'll put fragments of the allergen on their surface on MHC class 2. They'll also put co-stimulatory molecules, and these professional antigen-presenting cells will then go to the lymph node where these memory T helper 2 cells are, and they can then activate these memory T helper 2 cells in the same way as we saw long ago that you activate normal, naive CD4 positive T cells. Okay, this will cause signal 1 and signal 2 within the memory T helper 2 cell, and then what will happen is that will cause the production of interleukin 2 and the production of the interleukin 2 receptor alpha component, and this will cause that autocrine signal which delivers signal 3. Then what will happen is this memory T helper 2 cell will divide a little bit and then differentiate into T helper 2 cells. So it will go back to being T helper 2 cells. So this will produce a whole population of T helper 2 cells which are all mounted against that antigen fragment. Now this is going to occur far quicker than you produce T helper 2 cells against this allergen fragment in the initial primary immune response, because remember, you have absolutely loads of these memory T helper 2 cells, whereas you only had one naive CD4 positive T cell originally. So the chance that an antigen presenting cell will find a memory T helper 2 cell is far greater than the chance that it will find a naive CD4 positive T cell. So this will occur far quicker, and these T helper 2 cells then may well be involved in helping the reactivation of the memory B cells, but as I say, it's not well understood at all. Some people speculate that these aren't actually that important at all, that they don't seem to have a great deal of function, okay? But it's most likely that these memory T helper 2 cells do play a role somewhere. Okay, but whether it's with regards to the activation of B cells is controversial. I think most people would generally agree that memory B cells probably can be activated by the allergen alone. They don't need T help this time. Okay, because the T help was all about getting affinity maturation and getting isotype switching, whereas you've already gone through that process. The memory B cell has a fantastically good affinity antigen binding region on its immunoglobulin molecules, and it's already gone through isotype switching, so whether it needs T help is debatable basically. So it's likely that it can just be activated by the allergen alone, and then it will divide, produce a population of B cells which will then differentiate into plasma cells. Okay, so it will repopulate the plasma cell population. They'll produce IgE, and this is how you continue the IgE presence within your airway, because every time you have an asthmatic attack, you'll be relaunching the humoral adaptive immune response and producing IgE molecules. Okay, right, so let's now turn our attention to how the glucocorticoids work then. Okay, so we will come to the names of the drugs in a moment, okay? Because glucocorticoids, depending on your severity, the severity of your asthma, i.e. how severe the asthma attacks are when you actually have them, how life-threatening they are, and also the persistence of the asthmatic attacks, i.e. how regularly you have them. Both of these determine what sort of therapy you're given. Now, if you have reasonably severe but not too severe asthma, you will be given inhaled corticosteroids, which will be used prophylactically, okay? Whereas if you have really severe asthma, you will be given oral corticosteroids prophylactically, okay? So different drugs are given by inhalation compared to orally, okay? So we won't give the names of them yet, because at the moment we can discuss one pathway which is common to them all. So at the moment we'll just discuss our glucocorticoid in general. Okay, so let's see the way that glucocorticoids work. So basically, glucocorticoids go into the cytoplasm of cells, okay, and they are going to interact with glucocorticoid receptors which are within the cytoplasm of the cell. Okay, so in the cytoplasm of all cells, you have glucocorticoid receptors, which I will abbreviate to GR for short. So GR stands for glucocorticoid receptor. So this is a glucocorticoid receptor. Now the glucocorticoid receptors in a cell are not just free. They have a huge number of proteins complexed to them. Okay, so let me show you some of these proteins which are going to be complexed to the glucocorticoid receptor. Okay, so you have firstly, let's show a few down here. Firstly, you have two heat shock protein 90 proteins bound to the glucocorticoid receptor. So I'll put these here, HSP90 and then another HSP90. So this stands for heat shock protein 90. So H is for heat, shock is, well, S is for shock, P is for protein, and then heat shock protein 90, HSP90. You also have a copy of HSP70, heat shock protein 70, attached to this glucocorticoid receptor. Okay, now, also attached, which I'll draw on this side, you have a molecule known as P23, okay, P23 here, and also something known as FKBP52. Okay, so what does FKBP52 stand for? Well, it stands for the FK506, which is a drug that has since been renamed tacrolimus, which is a very powerful immunosuppressant. Okay, its main mechanism isn't that it binds to FKBP52. Its main mechanism is that it binds to a different protein, even though this protein is named after this drug. Okay, so tacrolimus, or FK506, binding protein, that's the BP. So the FK is for FK506, the BP is for binding protein, and then the F52 just refers to the fact that it's a 52 kilodalton protein. So there aren't 52 FK binding proteins. Instead, it's named 52 because that's its molecular weight. Okay, right. So here is our complex. It consists of these 6 proteins, and there are loads of different complexes that the glucocorticoid receptor can exist in. This is an example of one. Okay, so here we have the glucocorticoid receptor, 2 copies of heat shock protein 90, a copy of heat shock protein 70, P23, and FK506 binding protein 52. Okay, now, what's going to happen is the glucocorticoid is going to come into the cytoplasm of the cell, and it will bind to the glucocorticoid receptor. Okay, and when it binds to the glucocorticoid receptor, what happens is the glucocorticoid receptor is going to dissociate from these other proteins. So let me show this happening. So what's going to happen is you're going to get the glucocorticoid receptor over here on its own. Okay, and it will have bound to it a glucocorticoid molecule. So over here, this will be the glucocorticoid molecule. Oh dear, whoops, glucocorticoid molecule. Okay, and what's going to happen is that the other molecules that were in this glucocorticoid receptor package here, they're going to go off, okay? So they will remain complex together. So let me draw their complex over here. So here we have the 3 heat shock proteins all complex together, 1, 2, 3. So this is heat shock protein 90, another heat shock protein 90. Here's heat shock protein 70. And then over here we have P23, and then finally FK506 binding protein 52, FKBP52. Right, so now what's going to happen is this glucocorticoid bound to the glucocorticoid receptor is going to trigger all sorts of downstream pathways, but we'll continue this discussion when we see what this does in the next video.